greetings from Gangaram Hospital, and I'll just, over the next about half an hour, 40 minutes, I'm going to present the near miss cases which we managed. So before I ask everybody, I mean, everybody knows, as the chairpersons all said, that Deepshika also said, that is not the mortality now, it is we have to stop the near miss. The morbidities is what we have to handle. So what is a near miss event? A near miss event is any severe life-threatening obstetric complication which is necessitating an urgent medical intervention so as to prevent likely death of any pregnant or recently delivered woman in whom immediate survival is threatened and who survives by chance or due to the hospital care she received. Jyoti, am I audible?
Yes, yes, you're audible.
Yes,
And
yes. Screen also.
the screen is changing?
Yeah.
Yeah, yeah.
Yes,
Okay.
it is.
So why is it important to study this concept? So this near miss, or what we call severe acute maternal morbidity. Now studying cases of these type of women who nearly died but survived a complication during pregnancy, now childbirth or postpartum, they are a very useful means to examine the quality of obstetric care each one of us can give. Because if you can save a woman who otherwise would have died, it speaks volumes for your quality of obstetric care. So now how do you identify a near miss? Now initially we had criteria called Mantle's criteria, then came Waterstone criteria, which were very vague and not very specific. So now it has evolved, the story, and WHO systematic review presented three distinct approaches. A, either you define the clinical criteria related to a specific disease entity, like eclampsia, hemorrhage, sepsis, uterine rupture. These were actually the original Waterstone criteria. Or you can identify a near miss by any intervention. Supposing a pregnant woman is admitted to ICU with eclampsia, so that is a near miss. Or a procedure, like she had to get a hysterectomy done, a life-saving hysterectomy done because of placenta accreta. So either you can use an intervention like an ICU admission, or you can use some method whereby the organ system got dysfunction. She had shock, she needed ventilator, or she had a kidney disease and she has a dialysis. So finally we are going to go with the WHO near miss criteria now, which talks about six systems, I should say. So whatever system is dysfunctional, either cardiovascular or respiratory or renal or hematologic and coagulation system or the hepatic system or the neurologic system. So any of these six systems, if they get dysfunctional. Now what are the clinical criteria? So if it's a cardiovascular system dysfunction, the clinical criteria would be a shock or a cardiac arrest. If you see the lab markers for this case, then they have cut off limit of pH less than 7.1 or a lactate of more than 5 milliequivalents per ml. Now, what about the management-based proxies? Like if you have to use, continuous vasoactive drugs, you have to do a CPR. So any of these management-based proxies pertaining to the cardiovascular system, if it has been used, that patient is a near miss. And if she survives, of course, then it's a near miss. If she doesn't, then it's a mortality. Now coming to the respiratory system, the clinical criteria used are acute cyanosis, gasping, respiratory rate more than 40 or less than 6. The lab markers which we use as per WHO is saturation less than 90% for more than 60 minutes and FiO2 of less than 200. And the management, if you had to say intubate, ventilate these girls, these ladies, not related to anesthesia, apart from anesthesia, then again, this is a near miss. Now the renal system, if there is oliguria, non-responsive to fluid challenge or diuretics, or if the creatinine is more than 3.5 milligram per deciliter, or you used a dialysis, say if you used a continuous renal replacement, CRRT, for acute renal shutdown post-cesarean sepsis, then again, it is a near criteria. Then coming to the hematologic coagulation, patient is in DIC, doesn't form clots. Lab markers would be thrombocytopenia, and now we have added fibrinogen low, less than 2. And management, if you have used more than or 5 units of any blood or RBC. Then hepatic function, if it is deranged, you can have jaundice in the presence of preeclampsia. That is also considered a clinical criteria. Lab markers would be a bilirubin of more than 6. And neurologic is any loss of consciousness lasting more than 12 hours, or it's a stroke, or uncontrollable fits, or status epilepticus, or paralysis. And the last which they have used is an alternative severity proxy, wherein if you have done a hysterectomy following either due to infection, sepsis, or a postpartum hemorrhage not responding to anything. So once we know what is a near miss, now let us talk about some of the indices. So one indices which we use is a maternal mortality ratio, which is calculated using live births as the denominator. Now, mortality index is for each near miss event in order to evaluate the standard of care provided for each disease category. So what you do in this is that this will be defined as the number of maternal deaths due to a particular obstetric condition divided by the sum of all the near miss morbidities and deaths which resulted from this condition, which is expressed then as a percentage. So basically, how many women died versus the number of women who died plus their near misses. Now, this is a very important ratio which I want to tell everybody, that is the near miss versus mortality. This is the proportional between how many near misses you had and how many mortalities. And if you had a lot of, say, 20, 30 near miss and only one woman died, that is a very high ratio, means you have an excellent care, excellent care. The reverse is also true, that if you have a low ratio, that means you just could save one and you lost 20 mothers, 1:20, low ratio indicates a bad care. So certain other indicators which we use are like women with life-threatening conditions, or WLTC. This refers to all women who qualified either as maternal near miss or those who died. That is, it is the sum total of the near miss as well as the deaths. So if you see, WLTC is equal to MNM plus the maternal deaths. Next ratio which we see is the severe maternal outcome ratio, SMOR. This refers to the number of women who have life-threatening conditions, per 1,000 live births. So this is basically expressed in the per 1,000 live births. So this roughly gives you an estimate of the amount of care and resources that would be needed in an area or in a facility, because the severe maternity outcome ratio is basically nothing but the number of women you saved plus the number of women who died divided by the live births. Then the maternal near miss ratio, as I've told you, already refers to the number of near miss cases per 1,000 births. Now, I will just straight on, if with the permission of the chairpersons, if there are any questions, or shall I go ahead with my cases now?
I think you can proceed.
Okay, thank you so much. So the first case here is a 29-year-old lady who was admitted with very ATT-induced acute liver failure with 8+2 weeks of POG with IVF conception and a triplet pregnancy. It was a trichorionic, triamniotic pregnancy. She had a normal menstrual history, normal everything, but only scanty period since 4 years, with bleeding after withdrawal bleeding. And her last period was on 21st June 2009. Actually, these are all real cases, so the dates are actually corresponding, because I have a collection for the last almost 10 years of near miss. So here, she was a known case of hypothyroidism on treatment, and in view of the scanty periods with 1-2 positive, with infertility, a diagnosis of genital tuberculosis was made, and was empirically started on 10th May. That is before she conceived. And incidentally, husband was a HbsAg positive carrier. So now, ET was done on 7th July 2019. She was already on ATT since 10th May. So she was already 2 months on ATT. IVF done and 3 embryos were transferred. And initial LFT, which we had the report of 1st June, was normal. Now on 24th July, beta HCG was positive, and she came with repeated episodes of vomiting to her primary caregiver. And an LFT at that time was showing a deranged liver enzymes. And she continued with vomiting, pain, epigastrium, and then the yellow discoloration of the eyes started. So roughly you can say on 7th July when the IVF, and a month later she had jaundice. Now this LFT again was done on 8th August, and patient was asked to stop ATT as it was deranged, and it was admitted to some private hospital, managed conservatively, emetics, antibiotics, and then referred to another hospital on 13th August in view of persistent vomiting, poor intake, weakness, and progressive yellowish discoloration of the eyes and deteriorating liver function tests. She was put on IV antibiotics, IV fluids, PPIs, and other supportive medications. And ultrasound done at this other referral state showed a gallbladder edema, otherwise everything was normal. And the TVS done on 14th also showed triplets. One was 7.5, 8 plus 2, and 8 weeks. All three were alive. And during that hospital stay, her bilirubin shot up to 16.8. She developed flaps and altered sensorium. And this is how we had received this patient with grade 3 encephalopathy for further management on 17th August at 1 a.m. in the night. And on admission, the patient was drowsy, not responding to commands, icteric, tachycardia, and saturation was 90% on room air. 12-week size uterus, uneffaced cervix, os was closed. Now, if you see the bilirubin, this was on 17th August. It was 16.8 and direct 5, and more of an unconjugated, lot of hemolysis was happening. And OTPT was 111 to 95, prothrombin time was 320. And if you see the ammonia level was very high, she was in encephalopathy. Viral markers, etc. were okay, procal was okay. Now, what were the dilemmas? Question arises in this case with a high INR, with acute liver failure, with IVF triplets. So this is what we started with the dilemma. Now, it was fulfilling. We took in a reference from the liver transplant team, and she was fulfilling the King's criteria for transplantation. PT was high. Time from onset of jaundice to encephalopathy was more than 7 days. And it was a proven drug-induced liver injury, and she was already in encephalopathy. So just as I mentioned, I have mentioned these King's College criteria for liver transplantation in acute hepatic failure. So as you can say, pH is less than 7.3, INR more than 6.5, creatinine more than 3, and grade 3-4 encephalopathy. Or other cases of acute hepatic failure, you can have INR more than 6.5, or any of three of the following ones: age less than 10, more than 40, cause of is non-A, non-B, or idiosyncratic drug reaction like in our case, and duration of jaundice before encephalopathy is more than 7 days, and INR more than 3.5, bilirubin more than 70. So we did a check ultrasound here, and we showed missed abortion in all the three fetuses. Patient's family was counseled regarding need for suction evacuation, followed by a liver transplant. Ethical committee approvals and appropriate pre-transplant workup was fast-tracked. And we did a suction evacuation under ultrasound guidance on 17th itself with FFP, PRP, and a cryo cover as guided by the hematologist. And since the patient was already intubated, she had to be electively intubated for liver transplant. She was taken up for liver transplant with a living related donor, which was mother, because the same fast track was done on 17th August 2019. Now, the very next day, as you can see, her again total bilirubin was high, 29, direct was 18, OTPT was high, and INR was 3.9. But the very next day, as you can see, we are improving with our bilirubin, we are improving with our, slowly, we are improving with the INR. And this was managed by the liver transplant team. And on 21st August, the condition was looking still better. She was extubated. And on 4th September, again, bilirubin had come to 6.2 and INR was 0.9. So gradually patient was improving. So in a nutshell, the pregnancy outcomes, fertility, now this was a case of infertility with IVF triplets. So as per the criteria, it is patients who have undergone orthotropic liver transplantation often regain their fertility if it was due to a non-obstetric cause. Like if it's a tubal block and all, obviously she will not regain her fertility. And it is advised to delay conception at least 24 months after transplantation, so that to allow the stabilization of the immunosuppressive regimen and to ensure that the transplant organ is functioning well. And as per literature, both outcomes of mother and baby in the recipients are generally good, but slightly increased incidence of preterm delivery, hypertension, preeclampsia, FGR, and diabetes. And in addition, there is a slightly increased risk of teratogenicity with the standard immunosuppressive regimens, but the magnitude of the risk is uncertain. So basically, if it is on mycophenolate and mTOR inhibitor, they should be stopped at least 3 to 6 months before pregnancy. But you can continue TAC, cyclosporin, and steroids if they are. I mean, they have to be given, but not a mycophenolate and mTOR. So if there are any questions, I would like to answer.
Dr. Geeta, if you don't mind, I'd like to ask one thing. I think you all do an excellent job being a tertiary center to save the patient. But what is the learning in this particular case for the average gynecologist and the IVF specialist so that we can prevent such a thing from happening? So what were your conclusions from this case?
So, very good question, Jyoti. First of all, we were faced with an ATT started empirically. Okay, so one message is which we took was that in case there is a need for ATT, you should be absolutely sure that you need the ATT. First of all, is that. And second, of course, as a part of IVF protocol, I think it's better we do single embryo transfers, which everybody is doing. Right now, for the average gynecologist, that is what the message is. Third thing is, if you get stuck with this kind of an ATT induced and in encephalopathy, jaundice encephalopathy, then refer to a higher center, tertiary care center ASAP.
Yeah. And another thing I felt, within 2 months of starting ATT and IVF was done. She was already transferred. So the patient must have been on AKT4 by that time, because that's what an average gynecologist starts them off on. So when a patient has been started on AKT4, so normally we do not consider an IVF or an IUI or anything. At least she should have been on AKT2 before it had been started.
Absolutely.
And they had not done any monitoring of SGOT, SGPT, because
it's only when she had
just transferred.
It's when she had all those issues and vomiting, etc. That's when they thought it was hyperemesis gravidarum, etc. And it actually overlapped. The hyperemesis overlapped with the ATT-induced toxicity.
I wanted to ask, in 2 months on AKT4, such a level of hepatic failure can happen?
Yes.
Yes.
This is I think fourth or the fifth case. We've had 3-4 cases before this and many after this. One young girl for ATT again for I don't know what reason. Then 2 girls, 2 middle-aged ladies we've had for liver transplant following a drug-induced liver injury. So it's pretty common.
And I think that's why it's very important when we start an ATT, that within 14 days, we always do a LFT, call the patient up to see the compliance. We just can't leave them because it's a toxic AKT4 we are starting on them.
Absolutely.
So they can't be just left.
Yeah. Absolutely.
Can we delay plan of pregnancy, ma'am?
Absolutely. As Jyoti has rightly said, one should just hold their horses and let the patient and see how the ATT is evolving vis-a-vis the reaction and drug-induced liver injury.
Can I add something?
Please, yes
ma'am.
This is always sort of a conflict between gynecologists whether you should treat empirically with ATT or not, particularly in fertility patients. So many times when people have got PCR, although it is not diagnostic, but then even if you presume that it is latent tuberculosis, then the recommendation now is to give them only INH and not put them on 4-drug regimen. So, although in this case there was not much, no investigations done to show, but even if you do PCR,
Yeah, she only had
And
a ma'am.
if it is positive,
MON2 positive.
MON2 positive alone, at the most you can say it is latent. You cannot call it overt disease. And latent,
Absolutely.
again, like I said, even if you feel strongly that you must treat, then just put them on only INH. That is the recommendation.
Right, right. So, I mean, it's all very nice to, argue and discuss in the hindsight, but I am just presenting this case because this is what we got, and I'm just
Yeah, yeah.
presenting how we
No,
manage.
obviously,
But point is
you got
taken
it.
that all people who are listening should have this. A, not to take up the diagnosis of tuberculosis so lightly, have your house in order before starting.
Absolutely. Yeah.
And if it is a latent, just INH is more than enough.
Right, right.
And the IVF specialist not to be in a hurry, and the infertility. Finish the course and then take care of the patient up. Yeah.
Yeah.
Thank you. Dr. Geeta, please.
Okay. So shall I continue, respected chairpersons, with my, and please tell me the time limit because I've got lots of cases. So just tell me when I have to stop, please. Okay.
It's up to 4 o'clock. It is up to 4 o'clock.
Because they're all very interesting cases. I didn't know सबको ले लो. मेरे को लगा ये भी present कर दो. Anyway, so Mrs. B.
3:45, I think. We'll stop
3:45. So I just stop the machine rolling. So I'll get the interesting cases. So okay, here now, 34-year-old female, Mrs. B. She is primary gravida, 18 weeks, beta thal minor, both husband wife. She came to us with a rectus muscle abscess for management. She, since as I've already told, she was a beta thal minor, etc. PCOD. First trimester fine, herpes zoster, and then CVS was done outside on 23rd July because of the beta thal status. And after the procedure, the next day she had fever, pain, and then a rectus muscle hematoma. So Augmentin was given for 10 days and then comes to Gangaram on 16th August. So almost she came to us 3-4 weeks after the whole story. So here when we examine, nothing much, but here when you see her temperature, afebrile, everything is fine, 18-20 weeks. And we could feel that firm mass which had probably resolved, that hematoma, it probably becomes solidified over the right rectus muscle. We were very happy, chalo, theek ho jayega. And double marker again showed increased risk, but when the report of CVS came, it was fine. And beta thal carrier fetus diagnosed as beta thal carrier, right? QFPCR negative. We were very happy. So here we had this patient, and somehow she was not looking very, really nauseated, etc. So we also sent a liver function test. And when we got the liver function test, it was 1.9 bilirubin, and OTPT were deranged, 412 and 262, bile acid 19.1, and a reverse albumin globulin ratio. So then that is the time we thought, let's do an upper abdomen. When she got admitted to us on, I think that very day, 16th August. So we got an ultrasound done, and that, to our horror, showed a Budd-Chiari syndrome. The caudate lobe hypertrophied, atrophic lower lobe, and mid and left hepatic veins were not visualized, and the intrahepatic inferior vena cava was markedly stenosed. And she had been living a very happy life, excepting for a herpes in the first trimester. That's all. So that is when we formed a multidisciplinary team, and we talked to the hematologist and the gastrologist and Doppler evaluation. And then, of course, the whole story started, and ultrasound findings were confirmed. And we got the report of, as you can see, anti-cardiolipin antibodies, IgM, was sent. It was, of course, equivocal, and beta-2 glycoprotein 1, IgM was negative, IgG was positive. So some level of, we got an APLA positive. And C4, IgM were equivocal, and SSA and SSP were 3+. So now what is the mechanism of BCS? In very short, basically it is the thrombosis of the hepatic veins or the terminal portion of the inferior vena cava. And there are multiple risk factors for venous thromboembolism in these patients. And pregnancy is actually a thrombophilic state because of the increased levels of fibrinogen, we all know. decreased protein CS and S levels, and we have in pregnancy higher resistance to the activated protein C. In nutshell, it's a thrombogenic state. So being a hypercoagulable state, and women with a BCS is at a higher risk of developing exacerbation of their underlying disease. And the main problem in these cases usually is primary infertility, and supposing they do get pregnant, pregnancy is quite safe for mother and fetal outcomes. And in fact, we have done transjugular intrahepatic TIPS, what we call transjugular intrahepatic photosystemic shunt or hepatic stenting. And of course, they need anticoagulation. So you don't have to terminate such patients. So in Gangaram, then what we did this as I showed you the profile, and then beta-2 GP1 was positive, LMWH was started, and she had a little iron deficiency anemia. And so therefore we did normal ferritin levels, the myeloma profile was done, and probably a little polyclonal immune response because the free kappa and lambda light chain levels were elevated. So anyway, we continued in as a multidisciplinary.
Dr. Geeta, just a minute. Someone has shared their screen. Dr. Meera Hari.
Dr. Meena Hari Singhani.
Yeah, please stop sharing your screen. So
Okay.
that we can go back to the main screen.
Okay, just a minute.
No, not you, Geeta. Someone else had started sharing the screen.
Oh, acha.
You can just switch it off and then reshare, I think. Malti?
I am still sharing.
But
you want me to stop sharing?
You stop share and again share.
But she can continue. We can see her slides.
And it's coming as a very small. It's coming as just one of them.
Okay, where were we? So what we did, because I want to present more cases, I'm just going to flip it just to give you the take-home messages that this patient of serum bile acid 100, then 36, then she was followed with regular ultrasound and Doppler. वो मुझे guide कर दिया सबने. अब 2 minute wait कर दीजिए. So was regular ultrasound and Doppler with serial LFT and bile acids. We gave steroids at 28 weeks. And we had a severe oligo, non-reassuring NST with a poor interval. Weight gain was noted at 32 weeks. And then she had a loss of fetal movements for a day or so. So we did an emergency LSCS, male, 1.6 kg, was in nursery for 7 days. So as far as the consensus statement on pregnancy and Budd-Chiari is that in well-compensated patients with Budd-Chiari and pregnancy, maternal and fetal outcomes are good. Therefore, pregnancy is not a contraindication. And LMWH is preferred over warfarin. Now here is another case, case 3, Mrs. SP. She's 50 years old, 4th gravida, para 1, live 1 with 2 abortions, and IVF at 35 plus 3 weeks. She presented to our casualty with fever, cough and expectoration for 10 days, difficulty in breathing for 4 hours, but there was no fever, headache, blurring, etc. She was a chronic hypertensive and had been on labetalol 100 milligram 3 times a day, pre-diabetic on insulin. And first was a natural conception 23 years back, female. Then she had 21 years back a spontaneous abortion, and 19 years back an MTP. And now this is a donor oocyte IVF at a renowned IVF center in Delhi. Now, she was under antenatal care at the same IVF center on metformin, which was switched to insulin due to uncontrolled sugars at 20 weeks, and labetalol since the beginning of pregnancy. But when we received her, she was conscious but very dysnic, well-oriented, with a BP of 180/110 and tachypnic, bilateral pedal edema and bilateral rhonchi. Obstetric examination was uneventful. And when we did her hemoglobin PT INR, it was 1.3 borderline, and a bilirubin of 1.3 OTPT were raised. Creatinine and kidney profile was fine, and she had a 2+ urine albumin. And ultrasound showed a single live fetus, 34 plus 6, 2.4, BPS 6/10, and non-reassuring NST. So the same day we stabilized the blood pressure with IV labetalol. Chest physician reference was sought and treatment initiated for LRTI. NST continued to be non-reassuring, BPS 6/10, taken up for emergency cesarean after high risk. Now, everything was going fine. LSES was done, spinal anesthesia, Liker was thick meconium, blood loss averaged, male baby 2.15 kg, required little resuscitation, nursery CPAP, the usual story, you come IVF, high BP, you stabilize, everything was going absolutely fine. Now what happens? Now on the day of the surgery, she was fine. The next day, she had acute breathlessness with tachycardia and saturation was only 85% and oxygen by nasal pong started and immediately ICU call was sent. Now what do you think happened? I think everybody knows what happened. This is, yeah. So severe respiratory distress, 2 attempts were made to have tracheal intubation, but it was failed miserably. It was a panic situation. I mean, this patient, I remember it was a panic. She was shifted on a laryngeal mask to ICU on the bed. She was lying. Again, they attempted intubation under vision, but failed and she developed cardiac arrest. Now, 3 minutes of CPR, then spontaneous circulation could be achieved, and finally we could do a video laryngoscopic guided intubation, and this, without that video, I think we would have lost this patient. So this is a video laryngoscopic guided intubation, and now it was successful. And of course, she was acidotic, hyperkalemic, anemic, thrombocytopenic, and obviously a raised TLC. An arterial line, venous line, in a whole multidisciplinary team involving cardiologists, intensivists were involved, and all those measures were taken. And we also had to start a slow efficiency dialysis, which was maintained for 2 days. Now, on the 3rd day, she developed fever with abdominal distension. And ultrasound abdomen showed significant perihepatic perisplenic collection, and it revealed frank blood on tapping. Now, there was no pelvic or uterine, but upper abdomen collection. And obviously, we were also thinking it's probably a help with that's gone with DIC and a hepatic subcapsular bleed, probably as a part of the toxemia profile with multi-organ dysfunction and sepsis. So help with DIC, sepsis, and as per protocol, blood and blood products was transfused. And it was on day 5 that we could wean her off inotropes, and a tracheostomy was finally done. And day 6, again, slowly weaning was started. Now on day 9, we noticed a significant soakage of the abdominal dressing site with blood. So a re-exploration was done with the surgeon, and 200 ml of frank blood drained, but no active bleeding were there, no active oozers were sight, and drains were put, and they were removed after 4 days. Now, after 14 days of exploration, she was completely extubated and shifted to HDU, and over a period of time, she improved, thrombocytopenia settled, LFT settled, fever settled, tracheostomy port was removed, and discharged a month after admission. Of course, baby was discharged on day 7 from nursery, but there was some family dispute, and we'll go on to that later. The child has not been accepted by the family. Now, here is the case of, as we have all guessed correctly, pulmonary edema. And mechanism of pulmonary edema, basically we all know excess fluid administration. Like this patient got max sulf, and she is a case of severe PT, toxemia, and she was carrying a HELP. Others can be rarely cardiomyopathy. And Sibai et al. Have reported 37 cases of severe PET, 2.9% incidence of pulmonary edema was found, and 70%, mind you, were in the postnatal stage. So our case was fitting more into that. And you all know mechanism: increase in capillary leak, capillary fluid extravasation, secondary to vascular endothelial damage, and of course delayed postpartum mobilization of the ECF. Now, management, as I've told you, we've practically followed the book. You need an experienced team, a transthoracic echo, non-invasive ventilation should be tried first, like in our case, but it didn't work, so we had to do a laryngoscope guided intubation. And we used low tidal volume and low peak pressure, and urgent reduction of a high BP with IV antihypertensive. Sometimes even NTG has to be used. So aim is to reduce the systolic and diastolic blood pressure, and IV furosemide, then repeat doses are required. And of course, long-term management, these patients are increased risk of hypertension, ischemic heart disease, stroke, renal diseases, and close monitoring is required. And of course, ACE inhibitors are drug of choice, and you encourage weight reduction, cessation of smoking, diet modification. So I think I'm finished with the time. So 3:45 is.
I think we can do one more case.
Okay, so what do you want? This was a...
Dr. Geeta, about this particular case, what was the postpartum prophylaxis for DVT that you all had taken?
We actually initially when we had opened her up, there was blood and all. Us time to हमें कुछ नहीं दिया था, but later on when she settled, she was on ILMWH.
No, but after cesarean, considering her high-risk factors of the age, this and that, so did you routinely take these patients for the cried DVT?
No, within 12 hours we don't start. We were to start the next day, but before that only all these things happened.
अच्छा, मतलब DVT पम्प अगर भी नहीं लगाते हो आप लोग पेशेंट्स को जो हाई रिस्क में जाते हैं?
Pump तो लगता है, वो तो without saying everybody, even our minors get a pump, but LMWH is afterwards. So this is a inversion uterus. You want me to discuss this, or there is a case of acute liver failure with dengue?
And I think inversion uterus got that. This is a different.
So here was a para 3, 32-year-old. She delivered at 7 o'clock at a private nursing home outside and presented to our casualty at 9 o'clock in a state of shock. So she had postpartum collapse immediately after this delivery of her third baby, and obstetrician who conducted diagnosed an acute inversion, gave her IV fluids, uterotonics as per her statement, and she accompanied actually this. I remember this lady came with this patient to the casualty. So she was pulseless, BP-less, unconscious, severely anemic, uterus not palpable, and on local examination there was an inverted uterus with placenta in situ seen on local examination, and she was bleeding profusely. So immediately code blue was done in the casualty, and intensivist, anesthetist, gynae team came, resuscitated the patient, activated the massive transfusion protocol, and she was intubated in the casualty itself and started on inotrope support along with IV fluids and a blood. Now, placenta was, by the time we took her to OT, it was already detached, and uterus could be gently reposited back, but only partially in casualty itself. But still the bleeding, she was pouring, and uterus was atonic, and the attendants were explained about the patient's condition and informed consent and shifted to OT for an obstetric hysterectomy in view of atonic uterus with continued, I mean, she was just pouring. I mean, there was a trail of blood on the trolley when she was, I still remember when shifting in the lift also along from the casualty on the ground. And consent even of DO2 we have taken in this case. So we involved 2 senior anesthetists, the obstetric team, intensivists. Obstetric hysterectomy was performed while inpatient was still in a state of shock during hysterectomy and received almost 12 units of blood and blood products. Post hysterectomy, she was still in a state of shock, but little bit recordable BP we could maintain with inotropic support, and she was shifted to ICU on the ventilatory support, and as expected developed ARF, managed by the nephrologist, and extubated after 72 hours. Hemodynamics, of course, had improved, but renal failure persisted, and repeated hemodialysis was required for this patient, and it was only after 10 days that she could move out of the ICU, and dialysis continued. And to add to our worries, she developed postpartum psychosis. So that was also handled by our ABLE team, and finally discharged home after 20 days. Postpartum psychosis persisted, for which she continued, but I think she was lost for follow-up. We don't know about that status. So I think we leave all this all the time. We all know all these things, right? So I think that's it. We have another case of dengue and cyclic neutropenia, and we have currently a case which I have put today, which came just day before yesterday. She's also came in an intubated state, and eclampsia. She had eclamptic fit. She's having concurrently eclamptic press and Mendelssohn syndrome. So I'll stop this now, okay?
So we can have experts, comments from our experts. Dr. Renu.
Dr. Geeta, very interesting cases. But I must say we call them interesting only when the patient survives, because if dies then it's more tragic.
Yeah.
So, and near misses really are great learning stories.
Absolutely,
Because,
ma'am.
and it is very important that we share with each other and learn from each other. If we can save a patient from going into near miss, even that, I mean, is a great achievement. So thank you so much for sharing all these. And I mean,
I just need your blessings that we save the one upstairs. She is having Mendelssohn's. She had a clamtic fit, aspirated. Mendelssohn's ejection fraction is only 10, cardiomyopathy. And we are going to take her up for a suction right now because there's a little clot and a placental cotyledon inside. Her counts are 30,000. So I'm just seeking your blessing. Just going to OT now.
That way, Gangaram is very well equipped. I know,
Yes,
and you
yes.
have a great infrastructure and great
Yes,
team, and
yes.
I'm pretty sure she will survive.
Yeah, thank you so
So-
much, ma'am. Thank you for your words. Very reassuring to hear.
We can think of saving a Mendelssohn syndrome. Otherwise, I remember when we were PG students, we will never been able to save them.
Yeah, and I know Jyoti will remember. Remember, we had a couple of Mendelssohn. They were just found dead in the labor room. I don't know if Jyoti remembers. She just aspirated and died. वो rounds पे क्योंकि 20 पेशेंट हो गए थे हार्डिंग में. जब तक वहाँ round पे पहुँचे, we had lost. It was a Mendelssohn's.
Yeah.
But for that we can only say कि हम अपना कर्म ही कर सकते हैं, बाकी तो
जी.
ऊपर वाला है.
बिल्कुल ठीक बोला. I think at a point of time you just अपने हाथ हम खड़े कर देते हैं कि भाई अब जितना हो सकता हो गया. And if you notice, all these patients were referred through casualty. The inversion uterus was intubated in the casualty. Only the butt Chiari was a surprise. We were investigating the rectus sheath hematoma. We did an ultrasound and she has a butt Chiari. She would have died if we had not done any Clexane, etc. So
actually, butt Chiari is a very rare cause of infertility.
Very rare.
I have seen only one in my life till now. And that was also very interesting. She, I don't remember the whole story, but she came to me for primary infertility and I was doing her laparoscopy. And like routinely when I do laparoscopy, then I look at the pelvis and I go up and look at the, liver for any adhesions. And when I looked at the liver, it looked very strange. I had never seen a cirrhotic liver in my life. And when I saw, although I had never seen, but I knew, the way it looked fibrotic, I said, this is not normal. So I just obviously recorded all that and then came out. And then she was treated for, finally the physicians, the gastroenterologist made a diagnosis of butt Chiari. And she was treated for butt Chiari and she conceived spontaneously after that.
Yeah. So you have to be really vigilant and start the LMW is not warfarin, right?
Dr. Jyoti?
Hey, Shama.
Dr. Shama?
Thank you, ma'am. Dr. Geeta, ma'am. Actually, you have explained regarding pulmonary edema and all that. We need supportive team. That is most important. The way the tracheostomy was not able to do, then you have done with the video laryngoscopy and all that. It means otherwise the patient must have gone in the routine hospitals and all. So, but we need one proper ICU and we need the team. That is most important, I feel.
Absolutely. Because here the senior anesthetist also tried intubation. They couldn't. So it had to be, they just put it on bag and mask.
Then later you have gone for the video
laryngoscopy. Yes.
Nice, ma'am. All cases were nice. And the remaining cases, ma'am, we can discuss Dr. Jyoti, ma'am, some other day. Because I think all cases must be made.
Dr. Renu.
Yeah, definitely.
Dr. Renu to...
Ma'am, we have near miss we'll be having near miss cases presentations every month. So you are most welcome to present next month also.
Sure, ma'am. Sure.
Yeah, Dr. Geeta, I would like to just ask one thing. See, all the cases, as you rightly said, were referred cases to you. So when we are actually talking of near miss with a hospital which is so big as yours, because we are smaller hospitals, we are not able to calculate the near miss risk as compared to mortality ratio. So what is the index in your hospital for the near miss oblique?
Yeah.
Case wise?
Because this presentation has been switched off. I have a data we did a audit with us. Actually, that thing has been switched off. So we had in that 1 year case, we had 65 near misses and we had 5 mortalities. So our ratio was about 13:1. And I told you, if you remember, the near miss to mortality, higher the ratio, better is it. And if you have a good center, you have, like we saved 65, but we lost 5. So that is one.
And this you calculate case-wise? You are doing it system-wise? You calculate like cardiovascular?
Case-wise? No. We all of them included the WHO criteria. We collected all of them. कुछ hepatic थे, कुछ hepatitis E थे, कुछ एक status eclampticus थी. That status eclampticus we lost. Then another one we lost was she 18-week pregnancy. A truck ran over her. So we lost that. So, these kind of a thing. So we had 5 mortalities in that year, the data for which I have. And 65 we saved that year.
Okay.
65.
But among the patients which are inpatients like this, many must have been referred. I think
all of them.
So
all
within your hospital, the patients who are under the antenatal care of your particular hospital.
Yeah.
So what is the rate of a near miss in that particular or very high near miss oblique mortality who are only in yours, not the referred ones?
Yeah, I get your point. This one which I have is a 0 were booked and unbooked were 65 and 5 deaths. The one, I think, I don't remember actually losing any of our patients.
Because that actually talks about the obstetrical care of your hospital. We are looking of an antenatal care of your hospital.
We've had 1 or 2 unexplained stillbirths. One of my own patients, I was about to admit her at 34 weeks. IUGR chal raha tha, and 1 day before she had loss of movements. But I don't often remember one of our own patients going. These are all 65 of them were all unbooked casualties.
I can't
remember. Touch wood.
Yeah. Because if we do audit of these cases, we actually don't know how we can improve our obstetrical care. We have to know how we improve our obstetrical care by doing audit of our own cases. So over here, I think it's a big message for all the people working in periphery or nursing homes and everywhere. We learn from them about how we need to handle it and the right time to refer the patients. I think that's more important. It's the right time to refer.
3 delays which I always teach the PGs, the 3 delays which kill. You delay in the diagnosis, delay in transport, and delay in starting the treatment. So ASAP refer, ASAP diagnose, and ASAP start. Like in our case, last one I said we intubated her in the casualty, the one who had a inversion uterus.
Yes.
Like in the case you told about that 50 years old lady had pulmonary edema. But
pulmonary edema.
That's a message also to 50-year-old diabetic, hypertensive, going for IVF. I mean, that is a high risk she's taking herself such at age at 50 years of age.
Yeah, you're right, ma'am. But we have a tendency right now. We are getting 40-year-olds IVF done.
40, okay, but 50 is too much, I think.
Yeah, then she had only 1 girl, na? She had only 1 girl, so she has to have.
No, but that's not. I think Dr. Renu will tell us about the ART law, which has come now, where IVF specialists have to be very.
No. I was just saying that okay, at 50 you can still take the patient up. The idea is that you should first assess the patient whether she is fit to undergo pregnancy. Because even a patient at 50 might be good, and at 45 may not be so good. So if she had diabetes and hypertension before pregnancy, then she was really not the best candidate.
Yes, ma'am. I recently got one patient. She was 45 and she had menstrual problem. Husband had oligospermia, many problems, and her only daughter, 18 years old, committed suicide. And she had all diabetic, always hypertensive. I told her not to go for it now. IVF. वो कह रहा था कि सारे IVF के बच्चे नर्सरी में रखे जाते हैं और 30 लाख खर्चा होता है. So I said, why to go in for that? You should adopt.
No, but if diabetes and hypertension is controlled, I think they should be given the chance to have pregnancy. Because the age is all right, but if they are under control, they are taking their medicines regularly, and everything is under control. I think there is no point telling them not to conceive. But finally, at her own life, they should be under good supervision.
नहीं वो ठीक है, जैसे डॉक्टर रेनू ने कहा ना कि 50 वाला फिट हो
Evaluate, yes.
45 वाला
Yes,
नहीं।
yes. I think for the ART law, it is 100 years is combined age of husband and wife. So
Yeah.
it is 100 years combined. So if your husband is, you are 50, your husband is 54, so it's impossible. They should not be going in for that. But of course, IVF specialists, now it's not a matter to raise questions over here, but it's just that every patient should be evaluated for carrying the pregnancy.
If we can counsel them, if they are insistent, we have to.
No, we have to refer, but IVF specialists have the right to refuse.
No, so whosoever must have done IVF for her must have counseled her regarding the complications and all.
She must have.
Not necessarily. Nowadays, there is one IVF
It's a
center,
business.
har gali, har nukkad mein, and nobody is counseling.
Ma'am, I have seen they are not even doing blood sugar before doing.
That's what I'm saying. I have seen, sometimes in small setup, people, the anesthetist doesn't even look at the reports, before intubating the patient. उसके बाद देखते हैं. बहुत कुछ होता है,
Like this patient I'm telling you, the one who came with rectal sheath hematoma after CVS, we were totally distracted. CVS हुआ है, hematoma हुआ है, चलो ठीक है. Imagine she would have, jumped. It's a suicide to put, have a pregnancy and not know that you are a bachchiari. So that was just serendipity or our good luck or what. Because of the pain, we just did an ultrasound upper abdomen. But I think after that case, we have started doing upper abdomen for everybody. Just as a baseline routine. You can find some abdominal kidneys. एक kidney नहीं है, malrotated है, ये है, वो है. So we learn every day actually.
Yeah.
Actually, abdomen is a magic box.
Absolutely.
Pandora's box.
What you are going to
Pandora
get
box.
there.
Now, Dr. Praveen, you want to say something?
Thank you so much, Dr. Geeta. We had we had a chance to listen to such interesting cases, and especially the inversion uterus. One thing I would like to ask you: why did you go for liver transplant immediately? Like it was a drug-induced injury. Can't we wait for stop the ATT and wait for the enzyme to heal, manage her conservatively? Why did we go for?
She did improve. She was in NCAF. And as I told you, the King's College criteria continued to be in DIC, and the duration was more than 7 days from jaundice to NCAF. Bilirubin more than 6, so she fulfilled all the criteria, and she continued to be in the encephalopathy. Ammonias were very high, so because of that reason, and in fact, the same night transplant orthotopic.
Right. Because her mother was a donor, you could imagine.
Yeah, we fast-tracked it.
No, I think that was very timely done. Because in my experience, when I was in Safdarjung as a senior resident, I think all the maternal deaths I saw were because of severe anemia, and all the deaths I saw in AIIMS were because of hepatic failure.
Yeah, encephalopathy. In fact, I had another case after this, which was also in encephalopathy. She was hepatitis B antigen positive, had dengue with one of the DAN 4-5 strains. She came with encephalopathy, with a 28 weeks intrauterine demise. So luckily for us, she went into labor and pushed out the fetus in her diaper. Only she pushed it out. But we had a tough time saving her liver. She was also worked up for transplant, but she just came out on her own. Unlike our triplets one, she didn't come out of it. So
thank you. So we had a very nice webinar, very interesting, and looking forward to more interesting cases to hear from you. And we had a nice distinguished panel of experts. Thank you everyone for joining us. We go wiser, I think. Timely referral is the main thing for us routine obstetricians who have our own setups or small nursing homes. It's best to refer at a proper time. We do not delay to refer the patient. Diagnose and refer. That's to a tertiary care center. Yeah. Thank you so much. Thank you everyone.
thank you.
Thank you.
Thank you, Dr. Geeta. Thank you, Dr. Renu.
Thank you. Thank you. Thank you.
Thank you, everybody.
Thank you, Dr. Renu, for having us. Thank you.
Thank you.
Thank you,
Thank you to
everyone.
all the chairpersons.